minutes. Ok. Vamos iniciar a nossa palestra. Dear Professor James McLaughlin, good afternoon. Welcome back to our University of São Paulo, today at SEMEAD 2020. It's a joy and an honor to have you here with us. We look forward to hearing your talk. Thanks always. Paula, read your CV.
Professor James has over 300 peer-reviewed publication, government, and technical reports. He is a professor emeritus at Purdue University and currently is a professor of epidemiology, received his BA in industrial psychology and MPH in epidemiology and MS degree in environmental and industrial health. Professor James is a certificate professional agronomist, faculty, scholar, and professor emeritus of health sciences in College of Health and Human Sciences at Purdue University, and is former director of the graduate program in occupational and environmental sciences program. He created and directed Purdue Ergonomics and Exposure Assessment Research Laboratory, where his studies have won several national and international awards of their research. Please, Professor James, your words.
Great. Thank you, Paula, for the nice introduction. Thank you, Chris, for allowing me to speak before your students and health professionals. I'm extremely honored and very pleased to present to what I call my Brazilian family. Every time I've come to Brazil, I've always had a great time. And every time the Brazilians come to the United States, we just follow a joyful noise. And when we find that joyful noise, there's always the Brazilians having the time of their lives. So I am pleased and honored to present to you the information that I hope you'll find useful. Just fair warning to those that are participating, I do have a lot of content. I will send that information to you in a PDF file. So anyone who wants to look at the contents later can do that. As obviously, this is also being recorded on YouTube and they can watch that. But I'll give you both so you have a document as well as my presentation. So thank you again. I'm going to share my screen and get into this, my presentation. So this is the focus of my presentation is on human factors attributes of the surgical N95, respirator, and face mask during pandemics. But I cover a lot more because, as I was mentioning to Chris, that we are really in the middle of a major problem, something that has not occurred for 100 years. And it's like history, trying to explain history before the final chapter is written. But I'm going to do the best I can to talk about where we are. This country, I do a little comparisons with Brazil, and then move into the subject matter. And I will be going back and forth between the content of the PowerPoint presentation and my demonstrations, because the demonstration that I'm going to present to you will be something that I recall the what's next in terms of emerging issues in the United States. So for many of you, you may know that in the United States, there's a lot of mixed messaging about wearing a mask, a protective mask. Some people are wearing it, other people are not wearing it. But the next level is going to be once the new president comes in to power in January 20th, I believe that he'll have a national mandate for everyone to wear a mask. and that'll probably be enforced in some way. But the problem is going to be what kind of mask, and is it being worn properly? And I'm going to demonstrate to you that next level. So I want to present that because it's an interesting thing that just not any mask will work, and a mask not worn properly will not work. So I wanted to demonstrate that to you. I think it's an important element of this presentation. So to move forward, see if I can do that. I want to set the stage for where we are right now. This is what I picked up. This is as of last night, where we're looking at worldwide reports of confirmed cases that we have about 59 million cases reported worldwide. And we have almost 500,000 new cases reported with almost 1,400,000 deaths. And this shows where the deaths are, and you can see just by the intensity, the darker colors, where the high levels are. So it turns out that the United States and Brazil are very much almost bookends in this regard in terms of the high rates. Of course, the United States exceeds the world in this area. When I compared Brazil and United States, we have a base population of about 330 million people. You have 210 million. And just comparing the two with where we are, we have over 12 million confirmed cases. New cases just came up, almost 150,000. And then we have right now, actually, we've pushed up almost, we're near 260,000 deaths in the United States. And according to this, and when we come over to Brazil, you see we have 18,600, 6 million confirmed cases, and 169,000 deaths. And so you can do your math a little bit when you look at the denominator here on 210 million versus 330 million. United States is really pushed this envelope quite a bit. And I think most of it's really due to the lack of maybe some consistent policies and some of the politics associated during this pandemic with how to treat it nationally. If we look at the situation here, I wanted to show you how things are really taken off. We see confirmed cases are up and down through the summer. It increased, but look at what's happening in November. It's really taking off. In our deaths, we had a number of deaths where it seemed to be managing the fatalities a little bit more because we have treatment regimens that we understand. We also have some medications and so on. And of course, the vaccines are on their way, but we don't really see that being administered to the general population till probably the middle of next year, around June or July. When we look at Brazil, you had your really big push during your winter time down there through July and August, and your deaths also associated with that, but you seem to be addressing those issues, but you're now starting to see just a little bit of an uptick here as we head into November, December, your summertime. So this is something to watch on your end. Certainly for us, it's very challenging. This is what I'm most worried about right here. This, if you ask me what keeps me awake at night, our Thanksgiving is tomorrow. And it's a celebrated holiday. It's in our history. And the Centers for Disease Control, the agency that I work with for 22 years, recommended that people stay home, socially distanced, not get together with family and friends. And about 5 million people decided they were going to fly somewhere and get together with family and friends, and many more millions driving, kind of ignoring the recommendations from the CDC. So you see where we are relative to the other countries, including Brazil. Here you folks are down here, in terms of confirmed new cases. But look at where the United States is, really taking off. And I'm very concerned that when we get through our holiday, which is Thursday, Friday, Saturday, Sunday, people are going to be exposed, and this curve is going to increase dramatically. And I'm very concerned about that because right now we have doubled the number of deaths in this country from 1,000 a day to now 2,000 a day. We've doubled in the last week or so, and this number is going to continue to increase. And it's very, very unfortunate because there's not a person in this country doesn't know of somebody who's contacted COVID, and many who know those that contacted and have passed away. So this is kind of an interesting graph, and if you can bear with me, I'll show you this little timeline. It'll bring it up. Let's see if it'll bring it up here. What it does, if you go to this this particular website right here, this is put out by Johns Hopkins University. It will show you the numbers. Let me see if I can get this to come up here. No. Share. No, it shows you I can't do more than two things at one time. But what it does, if you hit this link, it'll show you a timeline of where it started out in Wuhan, China, and then eventually spread around the world, and where it is today with the millions of cases, over 10 million. And you can see United States is in big trouble right here, and to a lesser extent, Brazil. But you can see Russia has some challenges, India, and so on. And in terms of policy, this is cases by county, different counties we have within states. And this part of the United States are in the Dakotas, the North and South Dakota. And the darker the color, the higher the case rate. And so what this is a result of is basically a decree by the governors of that state not to wear a mask. And only last week, the governor of North Dakota said, okay, now a mask mandate is in place, but it's a little too late. South Dakota does not have a mask mandate. And as you can see, it is among the highest rates in the country. And when you compare it per capita in the world, the highest death rates in the world. And this is a result of some of the mandates being decreed by the governors of the state, and the lack of a presidential decree putting everyone in the country on the same page. So it's a big problem, certainly here in the Dakotas, and you'll see other isolated areas here in Arizona, Texas, and so on. So one of the approaches that we're looking at in terms of protection is this called the Swiss cheese approach. And this is brought about by James Reeson, who coined the term, describe how to deal with hazards from failures of complex systems and interacting with human, technological, and natural components. So with regard to the COVID-19 or the SARS-2, the barriers are there, the physical distancing, for example, wearing the mask, hand hygiene, avoiding touching your face, and so on. So each of these is a barrier, if you will, that by the time you put all these barriers up in place, that you hope that by the end, you're somewhat protected. And of course, that last layer of that Swiss cheese are your vaccines. So the idea is that now you've completely blocked it from here, which is very easy to be exposed to at the end, which is shared responsibility of those getting vaccinated. So this is an interesting slide to just show you how the disease spreads, because it now is based on probability and who gets it and who doesn't. So if we start out with number one, the source emission strength, if you're wearing a mask, you're just talking, or you're singing, there's going to be more viral particles that leave the body. Turbulence and airspeed is number two. So if you are close, but you don't have a lot of air behind you, those droplets will tend to fall to the floor and not go as far. Hence the idea of the 6 feet or a couple of meters or the length of a cow, which is what my granddaughter would say. When you have a lot of turbulence and air movement, the particles will tend to go a little bit further, especially the smaller ones, and I'll show you that a little bit later. And then the volume of shared airspace. The larger volume, they have less contact time. Smaller volume, like an elevator, you have more. But that's one of the reasons why they recommend being outside, is because you have more space. Next is time and shared space. The CDC had put out something that said 15 minutes is one of the conditions by which you may increase the probability of being exposed. Some people interpret that as that, well, if it's 14 minutes, it's okay. If it's 16 minutes, it's a bad thing. It's just a concept of being in a shared space for a length of time that people can understand. Because if you can put a number around something, people have a better handle on the concept of being in a particular area over time. And 15 minutes is something that most people can have a concept of. So it's not an absolute, it's really a guideline. Number 5 is crowdedness, being, let's say, during non-rush hour versus rush hour in trains that are moving, or how about the airplanes? Right now, we're seeing this in the airplanes in the United States because of Thanksgiving. And many of the airlines have given up that open middle seat. So now people are really right next to each other because the airlines want to make that money. They're hemorrhaging losses, and this is what's going to happen. And then finally, personal protection, that you can see here, wearing a mask and not wearing a mask. So the idea is that you have all these factors interacting with each other, forming a joint probability of a roll of the dice. Are you going to get it or not going to get it? If you have all of these working against you, where you have low airspeed, you're in a group that's singing, for example, at church, the choir, small space, with some in a hospital setting, for example, during crowded times, and not wearing a mask, the probability is going to increase dramatically. So the NIOSH, the agency that I work with at the Centers for Disease Control, has this inverse pyramid called the hierarchy of controls. And of course, the best is eliminating that source. In this case here, when eliminated by a vaccine, that's one area. But what you see most being used right now is personal protective equipment. And so here it is, the least effective personal protective equipment. The most effective is elimination. So why do we put so much emphasis on personal protective equipment? Because it's the easiest to control. It's available, we can control it, and it seems a bit upside down, but that's where a lot of people are right now in terms of wearing masks. So the United States, in summary for this part of the presentation, we're blinking red regarding the control of COVID-19. We have 4% of the world's population, but 25% of the cases. On Thanksgiving holiday and perhaps Christmas, we'll see a significant rise in cases and fatalities in the United States, perhaps even a doubling. You might see by the end of this year, something nearing almost 500,000 fatalities as a result of people not paying attention to protecting themselves. And the excess cases appear to be driven by policies and statutes. These are state laws championed by state governors and the current president of the United States. The limiting factor for an excess of deaths, in my opinion, it won't be a shortage of beds or equipment, but skilled healthcare personnel, especially nurses, those who are not sick with COVID-19, but also from fatigue and burnout. These are very important elements right here because when the first COVID cases started arriving at hospitals, there were parts of the country where there wasn't a problem, and then they would go to New York City, for example, where there was a problem, or California. The entire country now is on fire, if you will. We have fire everywhere, so you can't spare nurses from one state going to another state. So now they're calling in the National Guard and the military to help out in some of these hospitals, especially in these smaller states. So short term, the rate ratios for hospitals and deaths for the older people, the greater the risk for hospitalization and death is additional factors are if you're a male, our DNA is just not as good as the females. We don't have the protective factors as much as the females do. Being a minority, that's been a big issue in this country in terms of a disproportionate number of minorities having COVID. Having comorbidities such as obesity, hypertension, and diabetes mellitus are issues for the short term in terms of problems. Long term, this is something that's emerging now in terms of health. These are the younger folks who've recovered from COVID but have symptoms of fatigue, body aches, shortness of breath, difficulties concentrating, inability to exercise, headaches, and difficulty sleeping. So this is a big concern, emerging long-term concern. Think about chicken pox, for example, for many of you who are a little bit older who had chicken pox, and then later in life get shingles, right? So we have this adverse outcome of getting these shingles if you had the chicken pox. This may be something like that, but maybe even more severe. It's, oh, I got through COVID, no problem, I recovered. And now many of them are having these latent health issues. So stay tuned to that. What's interesting is when you look at age, it's somewhat, here's hospitalization versus death. And we're going to compare this to, let's say, a risk ratio of 1 to the 18 to 29-year-olds. So this is our comparison group. So if you're young, for example, hospitalization is 4 times lower, 9 times lower in terms of fatalities, 9 times lower for 5 to 17-year-olds, 16 times lower for 5 to 17-year-olds. But look what happens as you get past the age of 30. You start to see it increase twice as high, 3 times, 4, 5. By the time you reach 85 years, you're 13 times higher to be hospitalized. But look at your number for death, 630 times higher from dying. So if you're hospitalized, you have a very, very high probability of possibly dying the older you are. So this is something that's getting a lot of people's attention in terms of these rates that we're seeing in the hospitals. So my little quote here is that when politics and policies trump, they're like playing cards, right? Trump, I'm playing politics here a little bit. Public health, more people will die from COVID-19 as we're seeing with the holiday season and the lack of a national mandate for wearing masks. So I want to demonstrate now what I call a proper mask being worn properly. So I'm going to leave this and just show you something that I think you might find of value. First of all, when we talk about a proper mask, we have several things. We have one is that here's a mask that can be worn out. We have a lot of this, just a cloth mask, a linen mask. You put it on your face and you go out and say, well, okay, now we have a mask mandate and we're wearing this mask, we should be okay. Say, well, wait, there are maybe some issues with this particular mask. So for example, how about someone who wears it like this? Okay, we call it the sniffer, right? You're wearing a mask, but you're not wearing it properly. Or how about like this? You're wearing the mask, but you're not wearing it properly. How about like this? There you go. That'll work. Isn't that great, huh? Or on top of your head. There you go. That's a great mask, right? So the idea is wearing a mask and wearing it properly. That's one, but is it the proper mask? So then the question comes up about surgical mask. So here's a surgical mask and it's disposable. I see Chris has one. And you can put it on and you go out. And of course, these are made to be worn, just temporarily, and then you get rid of them. But what's the difference between this mask, for example, and this mask right here that I just showed you? Well, the difference is that the surgical mask, I kind of cut it in half. And as you can see, here's the outer layer right here, which is porous. And then the inner layer, which goes up next to your face. But you have this middle layer right here, which is a plastic layer. It's called polypropylene. And this plastic layer is the barrier by which it will block the air that's moving back and forth as you breathe, possibly exposing other people. So let me show you what I mean by that. So I put this mask on, and I call it the assassin mask, by the way. And you'll see why in just a second. So here I have it on. I'm wearing it properly. I'm not doing the sniffer. So I have it up, and my demonstration is kind of enlightening. I show this to my students, and it gets a wow factor. So can anyone see that candle okay? A little bit better. Really get that candle going. There we go. All right, so we have this candle right here, and I'm going to hold up and just my mask. Wow, what just happened there? I was able to blow through the mask. So what it is, even though I'm wearing a mask, the pore size, the weave of the mask is such that respiratory particles, the smaller ones, can get through. And even though you think you may be protected from someone else, that person may be exposing you, and they may have no idea that they're possibly exposing you. To me, this is going to be the big wave of concern when President Biden comes into place in terms of educating people about the issues of proper mask. Now, when I put on this mask, which I showed you had that barrier in it, I promised to blow just as hard. So we get the candle back out. I think I'd get a better candle for you. There it is. You can see it's not going out. And just to say it's one of those candles, and now it goes out. Now there's one other issue that comes up that you've seen, a point of education. I call this the Darth Vader mask. You've seen people wear it. I mean, in many instances, it's like almost a fashion statement, right? People wearing it. And you can see this mask has a valve in it. And I'm going to pull this over like this. And you can see the valve right here. And so what I'm going to do is the same thing. I'm going to light the mask, or light the candle. Light the mask. And here you're holding it up, and there's the thing, and I hope I can do this right. And now the candle's out again. Problem is that with these masks and the one-way valves, they're designed for comfort and moisture and reducing respiratory resistance. But the problem is that because of the one-way valve, you're still exposing people to the SARS-2, which can cause COVID-19. So not what you want to see in a line with someone next to you. They're not doing anything to protect you, because that's what these are all about, right? Just to sort of, if you're wearing one, they're wearing one, you're protecting each other from the spread. But the more insidious element might be something like this. It looks like it may be protecting you, but in some likelihood, it may not be protecting you at all, as I demonstrated. So a lot of times, to be safe, it's not a bad idea to go out in public in these surgical masks, which are not that expensive or hard to get, not in the United States. I don't know about in Brazil, but you can get a whole box of these for about $10. So this is my little demonstration of that. So wearing a proper mask properly, I believe, is going to be the next big wave of education, public health education, that we're going to face in the new year, in 2021. So you got a little bit of that in this presentation today. So I'm going to go back to my talk. And feel free to ask any questions along those lines after I get to the end of this. So moving forward then, the key differences to really the substance of my talk between the surgical mask and cloth mask are about size in terms of the particles that can go through. We're going to look at late breaking news from the CDC regarding mask protection, and a potential parting of ways between the director of NIOSH and the director of the Centers for Disease Control. Because I worked at NIOSH for 22 years, I know about this history. So you're getting some exposure to a little bit of the politics and the science intermingling with each other for some very high up people in the government who had a difference of opinion between surgical mask and N95s having the same protection factor as each other. And so they want to know where the science is. So my involvement in this particular side of the equation is that I've been doing a lot of work, mostly with anesthetic gases in hospitals, but lately with pathogens. And we evaluated a system that you can find on the internet called the Isoguard Mask. It's made by Teleflex. And it was basically designed to capture halogenated compounds from patients recovering from anesthetic exposures while they were in operating rooms. Well, what we did was said, if you can control for that, can you also control for pathogens? And so we did some experiments, and you can see here's a visual view of the mask itself. And this is a view of the pathogens on it, like COVID-19, using bioluminescence. And the brighter the pattern, the higher the colony count. And this is the exhaust hose right here. And you can see it really lights up with the pathogens. But what's most important is right here at the end, this is a HEPA filter, right? A high efficiency filter. And here's all the pathogens on one side, but on the outlet side, you don't see anything. So it captured these pathogens nearly to 100%. So using HEPA filters is quite valuable in the context of being able to control the spread of pathogens. So we're able to use this on patients, what we call source control, and it worked extremely well. Part of the challenge, though, was hospital administrators are saying, well, it costs $5 a mask. Not really sure we want to invest in that. Now they have an incentive to do that because of COVID-19. So as a result of my work there, they asked me to get a little more into this, and then the nurses then had me write a paper, which you're seeing some of the elements of that paper in this presentation, which have been accepted for publication in a nursing journal. So now just the basics to go through in terms of this separation. Just so that you know, obviously the face mask, as you saw, covers the mouth and nose and may not meet fluid barriers. The surgical mask provides a physical barrier, and it also looks to fluids and particle matters. That's one of the reasons why when I blew through it, I wasn't able to blow out the candle. So it has that barrier in there. Now we have the NIOSH approved 95 respirator and the surgical 95. Both of these are approved by NIOSH, but they're a little bit different in terms of the surgical 95s are worn by healthcare providers, and they're a class 2 device, and they involve particle filtration, but they have a couple more elements just in terms of flammability and also comfort and not being sensitive to the skin. So with surgical masks, there are 3 layers, and I showed you that. It helps to block large particles, splashes, and sprays, and also reduce your exposure, but it does not filter or block very small particles in the air, cough, sneezes, and so on, and does not provide complete protection from germs and other contaminants. And it fits loosely around the face. So as I put this on, as I showed you, there are gaps around the nose and especially on each side of the cheek for that. And so in terms of these cloth masks, then just keep in mind that for healthcare, ordinary medical mask and no polypropylene material between the layers. So this is what you can find on the market, which I was able to blow the candle out with, and it's not, it looks protective and it's not. So with surgical mask versus the N95, I put a little price count in here. We're looking at about 15 cents. It can go up to $3 if they're in high demand. In the United States, we have several scalpers that would take, extra money if it supply and demand issues. $3 to $15 for surgical mask. It's cleared by the Food and Drug Administration, evaluated and tested by NIOSH. It's loose fitting, tight fitting here. But I do want to say with regard to tight fitting, there are some problems with the way this fits, in particular females and Asian populations, but also it is not, fit testing is not being required by OSHA right now, our Occupational Safety and Health Administration. Why? Because of the high demand in which a lot of nurses have to use this, and the fact that they just don't have the resources to fit test them, which is a bit of a problem. So, and that was suspended in April of this year. Self-check required. It should be each time you don it, in other words, making sure that it fits properly. Filtration. The N95 is 95% of large and small particles, 95% of those being filtered out. Does not protect against the small ones. Leakage around the edges, properly fitted, it shouldn't leak. Disposed after each use and should be disposed, but because of a shortage, people are sanitizing them and using them more often, but that's a bit of a problem too. So I showed you this earlier in terms of what you can get on the market in terms of valve leakage. Notice that there is a NIOSH approved respirator with a valve right here. This is not to be used in hospitals. The ones that are used in hospitals from the various manufacturers, this is both the United States as well as out of China and Europe, are blue in color, just to show you that difference in terms of hospital versus not. This is more for factory, kinds of operations and so on outside of the hospital. This shows you kind of how another visual how it leaks. You can see breathing out here, and then of course here with the valve. So there's no protection right here. So if you're standing next to someone in line that's doing this kind of thing here, they're not really helping you too much, because if they are asymptomatic, there's a chance that they could expose you, versus a mask like this, which properly covers the mouth and nose and doesn't allow leakage. So size matters, just to give you an idea of reference. Diameter of a SARS-CoV-2 ranges between 60 to 140 nanometers. So if you look at an SN95, it removes more than 95% of all these particles with an average diameter of 300 nanometers or less. So don't look at this again as that fine line to say, well, anything above 300 nanometers, it protects against. Anything below that, it doesn't protect against. It protects large and small, but it's basically saying 95% of all particles in this range can be protected. And of course, the more you wear it, the more protective it is, right? Because it becomes a barrier in itself with all the debris that gets attached to the mask. So respiratory droplets are between 5 to 10 micrometers, or in this case, 5,000 to 10,000 nanometers. So much larger, and the viruses are carried within these respiratory droplets. To compare how big this particular virus is, it's between 60 and 100 micrometers thick. That means that the size of a single human hair comparable to the size of about 400 to 1,000 SARS-CoV-2 particles. So just plucking a piece of hair out and looking at the cross section of that, you can put 400 to 1,000 of these particles in there. So you can see it's very, very tiny, and it can pass through, especially around the mask itself, and can pass through easily the weaves of mask if they're not tight enough. So one of my favorite instruments out there is called a PAPR, which is a powered air purifying respirator. And it's loose fitting hoods over the top, but this is a HEPA filter right here that goes in there. It's got a pump, and it pulls the air up through. There's a little air curtain that comes down, and you can see the person's face, but it provides a very clean air curtain, if you will, because all the air is pulled through this HEPA filter. Its protection factor is 25 to 1,000. The protection factor of the surgical 95 is 10, just so you know, versus not wearing anything at all. So it's comfortable, but there is a problem with it, because for cost, let's say they're on average of these surgical masks I showed you, about 60 cents a piece or less. This N95s, as I mentioned, to get a box of those for about 30 bucks or about $1.50 each if they're available and not on the black market. But the PAPRs are about, and this is a low price, about $1,200 US per unit. So obviously this is going to be limited in terms of distribution. So what happens is a lot of folks are going to get this because of availability and price. Fewer are going to get this because of availability and price, and even fewer still because of this variability in price. So this, you're going to get in a little bit of the politics here, the late breaking news from the CDC. This just came out a little earlier this month, said masks are recommended as a simple barrier to help prevent respiratory droplets from traveling in the air to other people, called source control. The mask can help reduce inhalation of these droplets by the wearer. Multi-layer cloth masks block release of exhaled respiratory particles. And it causes cloth masks not only effectively block large particles, they also can block exhalation of fine particles, often smaller than 10 microns. Now they have, I'm going to supply those references to you where they come from, but many of these are international studies, many are anecdotal and so on, but they came out with this. And if you've been watching the news, the current director of the CDC is, we'll just call it subject to political persuasions of the president. And so some of the information that has come out has been quite interesting lately, this Dr. Redfield. So it blocks up to 80% of those that have been measured. And some materials, I call it polypropylene because it's, the skin doesn't react to it, may enhance the filtering effectiveness. And I did show you that it does really a good job of blocking at least direct respiration. So not too many people know this, and you're seeing this for the first time. The rest of the world doesn't know this, but I know this because it's called inside politics. But there's been a 20-year struggle over the efficacy of face masks versus the surgical 95s. And this goes back to Dr. Howard and Julie Gerberding. So Dr. Howard is reported to Dr. Gerberding, who's a director of the CDC back in the early 2000s. This is the SARS-1 outbreak. So what happened is that Dr. Howard was not reappointed NIOSH director of the CDC, and his term ended in 2008. It was a very controversial decision that was brought out. And what happened is that Sebelius, who is the Health and Human Secretary for the United States, announced Howard's reappointment as director when she came on board a year later. But what happened is that Dr. Gerberding, who was at the CDC, didn't decide to reappoint Dr. Howard because there was a battle between Dr. Howard saying the N95s are more effective than surgical masks. Dr. Gerberding said, no, surgical masks are just as effective as the N95s. So where this big battle went on, and Dr. Howard held his ground and said, I am not agreeing with you. We're going to disagree on this particular point. This is kind of a big deal. And because of that squabble between the two, Dr. Howard's appointment came up, and Dr. Gerberding says, I'm taking care of you. You're gone. You're not going to be reappointed. You're out of here. But what happened is that because Dr. Howard stood his ground, when the Obama administration came into power on January 20th, 2009, Dr. Gerberding resigned from her post because she was told that it's probably a good idea that you look for another job. As a result of that, Dr. Howard was brought back in to NIOSH, and he gets the current director of NIOSH. So it's interesting how the science trumped the politics versus a change in office between the presidents before Obama and after Obama. So interesting kind of news if you like that kind of stuff. So here's our surgical mask. And of course, as I mentioned, you, it's sort of a teal here of the surgical 95 respirator. And there are a lot of problems with counterfeiting. So there are ways of tracking to make sure it's not counterfeited in terms of going online and being able to determine that. There are checks and balances there to make sure that what you got is a certified mask. But what's interesting as I get into the human factor side of it is this is a bivariate panel, face width and face length. And so the idea is to measure, these are people that are in each one of these quadrants right here that are measured for designing the mask to fit. And then the manufacturers are given this information and they design the mask. And the masks come in 5 different sizes. But it shows you there's only about 18 people that are really tested in this test panel in order for that mask to pass in terms of its design. So it's no wonder that a lot of females, and in particular Asians, who may be in the healthcare business, are wearing these respirators and they don't fit, which is a problem. So the bivariate test panel then is a guide to manufacturers making small to large masks. They don't fit all faces. The wearers don't have a good face seal, and they may leak. So you can see where some people in healthcare, many of them would be wearing these masks and they get COVID-19. They say, how could this happen? I was wearing a mask. I was very careful. It could be because the face seal didn't fit appropriately. So laboratory studies have done to show leaks to poor fit and so on become problematic. And also if you have facial hair, it's not a good idea. You see some people wearing, a mask and they got a big old beard or something like that. It's a problem. So that's another issue for leaks. So where are the challenges here? Obviously, there have been shortages. These are filtering face piece respirators. That's what the FFR means. There are shortages we've had. Healthcare personnel had to work long hours, 10, 12-hour shifts, day in and day out. They've not been fit tested. When they are fit tested, they have assigned a protection factor of 10, which basically no more than a tenth of the contaminants can get through. But because they're not fit tested, this protection factor may not apply. The FDA requires biocompatibility and flame resistance and to meet test requirements by NIOSH. By the way, NIOSH now does a lot of the work for the FDA and they're a pass-through. So the FDA gets involved when you get medical concerns involved, like the medical side of the N95s. There are human factors attributes that limit things such as inhalation, exhalation resistance requirements, and the burden of wearing that particular respirator. So that also has to pass. But then the key thing right here is when you see this set point of 300 nanometers, just remember that we're looking at that 95% efficiency of both larger and smaller size particles for the particular aerosol that we're talking about. So the government then looks at things like pressure differential and filtration efficiency and so on. But two of these attributes touch upon the human factor side of things, and that is breathing resistance and biocompatibility or skin irritation. Those are only two things right there, and you'll see from the human factor side of it that there's going to be a lot more involved. So let's see if I can get this to work for you. So this shows a person sneezing, and you can see the particles out here going out. This is a very sneezy person, a lot of liquid. It doesn't look all that great, but you see the distance out here that it's going, about 20 inches out. And so these are the larger particles that you can see that are going to drop down out of the air pretty quickly. And then there's another graphic that shows you now we've doubled that distance right here. And this is sneezing right here. And here's a spray. And look how much further out these particles are going. And the spread right here, you can see many of them are dropping down, but you can see all these other particles that are still suspended in the air. This is one of the reasons why they say, it's important to be in a well-ventilated room and so on, because these things can remain suspended. And then finally, we look at 23 to 26 feet. So several meters right here, and you can see that particular plume where it's going. So, quite interesting when you can go to that particular level. So let me see if I can get you back to where I need to get you here. Patient and get there we go. Whew, I was worried I'd messed that up. Let me get you screens back. There we go. Thank you, Chris. She's smiling. So we see that we have basically particles can go quite far. Most of them drop down to the ground. That's why they say a length of a cow is, your distance, the further the better. But most of the particles in terms of aerosols tend to drop out about a couple meters. And so it lowers your probability. But there are the smaller, finer particles they'll carry out as much as 6-7 meters. So this is really the essence of looking at now the epidemiology between the surgical 95s and the surgical mask. And this was just came out 2020. It was in the Lancet. And the thing I really want you to focus on right here is looking at what the relative risks are in terms of wearing a mask and not wearing a mask. And these are all these different studies that were done on the meta-analysis, the respirators, no, yes, respirators, and looking at infection from SARS, COVID-19, and so on, events with a mask, events without a mask, and then your relative risk over here, your 95 percentile grade in that. And one is obviously no risk, and then you can go in the protection side favoring wearing a mask, and then the non-protective side favoring wearing no mask. And you can see that just about all of these studies show that obviously there is a protective mechanism from wearing a particular mask. Well, you think, well, that's all that great. And again, there are many of the masks in here that would be of the surgical 95s. And what I'm trying to show, if you see that, the protective side, it looks pretty good. And you say, well, then there's not an argument here. The N95 should work over the surgical mask. And this one, when we just specifically focus on the 95 and surgical mask here, and we look at SARS and MERS and COVID-19, you also see the same kind of protective mechanism. Many of them not, hugely protective, but some are. And these are, relatively recent studies here. The problem is they're not randomized, and many of them are not blinded in any way. So there's a lot of bias in the reporting of how this comes out. So there's some concerns with this, but it looks like the general trend is N95s obviously are more protective, certainly more protective than not wearing a mask at all, and slightly more protective compared to the surgical masks themselves. But the story is not over, because if you go to the New England Journal of Medicine, and there are a number of these kinds of studies, I picked this one out just for the sake of time, because it just follows a general curve of the other reported literature. Here's a randomized study of surgical 95 respirators and surgical masks when caring for coughing or sick patients during influenza season. A fairly good size, almost 3,000 participants and so on. But they collected this data over 4 years of flu seasons and looked at the cumulative incidence of laboratory confirmed influenza reported to be similar in both groups, wearing the surgical 95 versus the surgical mask. And so you say, oh boy, here we go. We're going back to this. And so the idea is that Zuger's study, which is just 2019, makes the point that perhaps it's a matter of wearing some kind of mask to keep the wearer's hands away from their nose and mouth so that large droplets and sprays are kept at bay, at least for highly vaccinated populations, which he was looking at. In other words, the mask itself provides a protective barrier from that. But many times, if you're not wearing a face shield or glasses, you may touch your eyes and the tear ducts, and it can get exposed that way. But also the lack of a good fit between the surgical mask and the N95s may come into play, or some human factors attributes. So in randomized double-blind studies, obviously are needed to settle the argument about protective aspects of surgical masks. And so, and I don't think that the COVID-19 pandemic will settle this matter, mostly because, one, we're not fist testing the mask in health care environments, and also in a contextual way, and this is where the problems of the other studies have been done, we have to look at the environmental, personal, and human factors roles that are played in this regard. So now, after more than 20 years of pandemic-related research, it is clear that there are individual and possibly a combination of human factors attributes, discomfort, temperature, respiratory resistance, and so on, that come into play regarding these two types of masks. So I pulled together hundreds of articles, and these are the general aspects of human factors: visibility, communications, breathing, physical performance, controlling the temperature, facial hair, anxiety. These are the general aspects of respirators, but the specific aspects of the surgical 95s are face seal, heat exposure, skin irritation, being able to hear someone talk, breathing resistance, and people feeling claustrophobic when they wear the mask. So Obviously, when you wear the mask, you're protecting yourself to a certain degree of the SARS-2 and getting the disease. But in terms of visibility, how many of you have worn, a mask and your glasses have fogged up, right? It's just like you can't see, and so that becomes a problem there. So visibility is an issue. Verbal communications. It's kind of interesting. Simple words and phrases are not understood at least a third of the time for people only a couple of feet away. So as you know, when you're talking to the mask, you can't really hear very well, right? So there's a communications problem. When we look at breathing, there is resistance that accumulates, and there's a bit of an increase in carbon dioxide. Some people are sensitive to this in the dead space of these respirators, and performance can decrease by about 20% because of this. In terms of physical performance, decrease in oxygen consumption increases the complexity of the respirators and so on. So the more complexity the respirator, the more the resistance can be there. The exception being the PAPRs, right, which basically provide an air curtain. Also, you have thermal discomfort and potential hypothermia. And when you get into coughing and sneezing and scratching and other issues that come into play, people will don and doff the respirators, take it on and off. And facial hair is a problem because of leaks around the beard, and anxiety and work performance. With regard to the surgical 95, there's leakage around the face. I talked about that. Heat exposure, especially for prolonged wear. And then this microclimate inside the mask, if you're wearing it for long hours, causing the pimples and rashes and breakouts around the face. You can't hear as well. The auditory problem is an issue. And so they found if you speak in complete sentences rather than short question and answers, it's better to communicate. Can you imagine the medical errors that are occurring because of this? There is breathing resistance, and a lot of people report being claustrophobic in wearing these things. And that's why a lot of Americans, when they go out shopping and so on, don't wear a mask, claim they get claustrophobic, and they have a medical release that they don't have to wear one. They say, well, it doesn't release you from wearing a face shield in some way. At least try to protect people in some way. So these are the kind of the outbreaks that you see with people in the healthcare profession wearing the mask over prolonged periods of time. Much of this isn't caused so much by the contents of the material of the mask as much as that little microclimate around the face from the breathing and bacteria that accumulates over time. So there's a physiological burden of wearing this, a long shift that people report getting dizzy, get dehydrated, they tend to hyperventilate, they elevate the carbon dioxide, and lots of anxiety issues from wearing these masks. Again, pointing to taking the mask on and off. So conclusions and takeaways from the literature, and I mostly focus from 2000 up to the present time, because when SARS-1 broke out, we had a whole avalanche of those that followed, right? MERS and Ebola and so on. So one, in terms of the human factors, there needs to be a systems approach that really looks at the surgical 95s to understand and link the human factors attributes of the 95 respirator for healthcare workers. Extended use and reuse. There's some caution in using this because you can't wear this for 12 hours a day, take it off, put it on the next day, and not expect to have health problems. One size doesn't fit all. I showed you that with the mask leakage. Clinical efficacy in the 95s. This is a real big take-home point. What we see in terms of the evidence coming out of clinical settings and saying we don't really see a big difference between surgical mask and the N95s, but yet in a laboratory we do, may be attributed to all these aspects of the human factors coming into play, such as irritability, fit, microclimates, respiratory resistance, and so on. Taking on and off becomes a factor. How many times they do that because it's not comfortable. And you have the physiologic and physiological concerns where we're looking at overuse and well-being. And then respirator design. The need to understand what are these design trade-offs to where abuse and use laws and regulations for these in terms of pandemic emergencies. So the brief literature review then shows you there's been a few decades of excellent lab work, very little epidemiologic work showing the efficacy of these respirators. So there's a gap between those two. We need more human factor studies, obviously, and many will come after we've written this final chapter in this pandemic, which we are now in the middle of, I believe. And so here are my takeaways in terms of that literature. There's a lack of a clear distinction between the superior performance of achieving protection of 10 in the laboratory and less clear outcomes from epidemiologic and clinical studies. That's one of the reasons why physicians will always argue with the scientists about this big difference between the two. They propose that discomfort from wearing the surgical 95s may result in the wearer breaking the seal between the face and the seal, and that discomfort caused here may cause the occasional leakage of the virus particles going in, therefore blunting the differences between a surgical mask and the N95s. It's further proposed that surgical masks may be made more comfortable by wearing them, and it could explain these discrepancies. So I'm going to end my talk with a recommendation on this particular book, which many of you may have read. If you haven't read it, it's a really good read, and it's called Apollo Zero. And Christakis does an excellent job of really taking you to the ins and outs of all the technical aspects in a very clear and understandable way of where we are and where we're going with regard to this pandemic. So with that said, I end my talk and I open myself to any of your questions that you may have. And I thank you in advance for your time and attention. And again, also to tell you how honored I am, Chris, for being invited to present to your organization and hope that some of this information is of some use to you. Obrigado.
Thank you, James. Great, so important your presentation. We are in TV, SEMEAD, and in YouTube. Then the people are around. Next time, Lígia, make the questions, please.
Okay. Professor James, thank you so much for your rich presentation. It's very important, the topic that you just share with us. And I have here a couple of questions for you, okay? As a matter of fact, I have 4 that I picked. So I will read one by one in English for you, and then I will translate for the audience. Is that okay for you? Okay, so let's go. Okay, so the first question that I have is, what are the difficulties of using the mask in children and the elder people? Em português, quais são as dificuldades do uso da máscara nas crianças e nas pessoas mais idosas?
It's a great question for the elderly and as well as for children, because there's 2 sides of this, and very young children. I'm speaking of those that are less than the age of 5, in particular, up to a couple of years of age, which, by the way, they are not, children less than 2 in the United States aren't required to wear a mask. But if they're older than that, they're old enough to understand the importance of wearing it. So parents often serve as good role models to be able to instill in the children that wearing a mask is okay. And obviously the fit has to be there as well. So you have to find masks that are small enough. For the elderly, we're looking at problems of donning and doffing mask if they have arthritis problems, putting it on and putting it on properly and understanding what they're doing, especially the very old, those over the age of 70, 75, where the risk of death is much, much higher, excuse me, than younger people. So arthritis issues 1. Number 2, making sure that they seal that wire, that comes with it. So they shape it, around the nose so that it fits properly, and they put it over their ears. The other is their ability to communicate. Often when they're covering up their mouths, the communication is not as good because the older people tend to talk softly and they tend not to like to wear these. very much at all. But it is, complicating process by not only the manual dexterity of putting it on and off, communications, and then in fit.
Thank you. I have here another question that is related to the beginning of your speech. That the question is, I have been in North Dakota region and I realized it is a community of a very traditional thoughts that may implicate behavior against accepting COVID-19 reality disease. In this sense, the government media has a great responsibility in providing the real and right information to the population. In this line, Professor, governments should not be responsible for a lack of health norms and the deaths of the population.
Ooh, that's a loaded question. I will speak more from the context of the United States, and then you can take what you will to your own application in Brazil. I do read the news down there. You're very interesting, your politics, and you've noticed that sometimes politicians are not on the same page, right? The president says one thing, the governor will say something else, and the people are saying, what are we to do? In our country, it's been a disaster. And the reason is that we've not had a national voice, a national leader indicating that wearing a mask and providing those resources for all states, all 50 states in the United States, has resulted in a very uneven understanding of respiratory protection and the importance of it versus being exposed to SARS-2 causing COVID-19. So as a result of that, some states are saying, we don't need a mask, don't have to wear a mask because we're tough, we're Americans, we can't be told what to do. And others are saying you should wear a mask, you need to wear a mask because you're not only protecting yourself, you're protecting others. And so this unevenness has resulted in many epidemiologic experiments where the states that don't require wearing a mask are having much higher rates, as I pointed out in North Dakota and South Dakota, for example, highest rates in the world per capita, right? Which is crazy when you think about that, versus other states like in California where they do require wearing a mask, much higher population where the rates are a lot lower. The problem is that it's hard sometimes for people to conceptualize something so small and tiny that they can't see that can kill you. And it's not known, as I said, that sometimes like the assassin mask right here is that you might go out be wearing this thing, but yet you're asymptomatic, exposing someone, and they are now getting it, and you have no idea. You say, well, maybe you got it when you were in a checkout counter getting food. So the problem is that we're at a point of division in the United States between those that think they don't have to wear a mask because it's their body, their life. But I say to you, we have laws that say you can't drink and get behind a wheel and drive. You have to wear a seatbelt. You can't smoke in certain environments because not only does it kill you, it's going to kill others through secondhand smoke. So we can see a number of these things eventually getting out. Why? Because they're national policies, not state policies. And once that happens, the next thing that has to happen is a solid educational program to help people connect the dots and say, we get your individual rights, but if you don't follow these guidelines, you're likely to die.
Perfectly. I totally agree. I will translate in Portuguese because I forgot.
Yes. Sorry.
No, that's okay. Pessoal, então a pergunta foi, a pessoa esteve na região da Dakota do Norte e ela percebeu que a comunidade ela tem um pensamento muito tradicional naquela região e que isso pode implicar no comportamento de não aceitar a realidade do Covid-19 nos Estados Unidos. Então, nesse contexto, a pergunta foi, o governo / mídia teria responsabilidade em prover uma real informação sobre os perigos, né, sobre a questão da não utilização da máscara? Então, nesse sentido, eles deveriam, o governo, né, no caso, ser responsável pela falta de normas de saúde e com as possíveis mortes. Então, é óbvio que esse contexto não se aplica só aos Estados Unidos, né? É um contexto muito mais amplo, que tem muito mais a ver com culturas ou com mindset. Okay, Professor, so I have another question here.
Lígia,
Yes.
Lígia, se puder passar para o inglês, ele disse que, assim, que a gente tem também uma política interessante sobre essas questões, né? Então, esse desafio do interessante versus a responsabilidade pelas mortes, como a gente está vivendo momentos semelhantes. É só um comentário, se puder traduzir para ele para o inglês, fica mais preciso.
Para traduzir ao professor, você diz?
O professor Deu?
Desculpa, poderia repetir rapidamente, professora?
Sim, é que quando ele respondeu a questão da Dakota, do Norte, ele falou que o nosso país está com uma política interessante sobre isso.
Ah, ok.
Então, assim, curiosamente, temos problemas semelhantes e responsabilidades e perdas semelhantes. Só para ratificar.
Yeah. Yes, Professor, I am translating Professor Anna, and she says that we have a really interesting politics being applied here in Brazil, but in the same sense, we have same issues as well. Therefore, we are working together. That's why I think this question is important, because it's overcome barriers of countries. It's a matter of behaviors, a matter of a mindset, right?
Thank you.
Okay. Another question, Professor. I think we have 10 minutes left. Then what are the other procedures that guarantee quality of life at COVID-19? Pessoal, quais são os outros procedimentos que podem garantir a qualidade de vida na COVID-19?
That's a great question. You know, in this country, you don't see a lot of it publicized elsewhere, but as a public health professional, I see it a lot. Suicides are way up in this country. Domestic violence is way up in this country. Children being abandoned is up in this country. And the mental stress that everyone is feeling, not only in the healthcare community, you know, think about this. You know, we have people dying every minute. Since I've been giving my talk, just in the United States alone, over 90 people have died from COVID-19, very stressful. But there's a lot of mental stress going on, not as much physical stress, but the mental stress of not knowing how this is going to play out. Now, with the vaccines coming, that is a ray of hope that looks really very promising in the new year, but that's going to be 3 to 6 months to 9 months away before people in this country are going to be vaccinated. I think about the same time frame for Brazil. And until that time, people have to assume a frame of mind is saying, well, this is something we've not experienced in 100 years. Certainly none of us in our lifetime have experienced something like this. And you have to take what you can to reduce that stress and so on. So for me, for example, I play my grandson, I play chess with him. He lives in Australia. I've taken up the ukulele. Play a ukulele now. It's strum for my own mental health. And then I write papers and I present. And that helps me. And I think people need to find where they can be comfortable in the social distancing and isolation. So for example, tomorrow we have Thanksgiving. We're usually with family, but only my wife and I now. But we're going to Zoom our family and have a virtual meal with them. So we have all these issues in the United States, as you see, the very worst, but also you see some of the best that are happening. Plus, we have a new president coming in January, and we're all very hopeful that he can get us all on the same page, reduce the temperature, reduce the stress, and bring out the vaccine.
Well, good to know that you are having a great time providing this speech, because you said that's something good for you. Thank you. Okay, another question. Here in Brazil, there is a craftsman who is making masks imitating the person's face. What do you think about this art in terms of mask? I don't know if you understood my question, but it's somebody that's crafting a handmade mask to look like the person. So what do you think about?
Well, if it protects, it protects properly, that's fine. But if not, it's a problem, as I showed you in terms of the protective aspects of that. There are a lot of entrepreneurs that are going out and making masks and so on, but many of the entrepreneurs don't know the protective mechanisms that have to come into making a proper mask, and when they don't, through their own ignorance, even though they're making some money on it, they may be causing more harm than good. So they have to be very careful about that.
Yeah, very important. A pergunta, pessoal, é sobre essas máscaras caseiras, né, que o pessoal faz, tanto no âmbito de máscaras tradicionais, quanto máscaras personalizadas, né? E o professor diz que, contanto que atenda, né, os requisitos, ok, mas caso contrário, a gente tem que tomar cuidado, né, ao adquirir esse tipo de máscara, se não provém a real adequação e proteção.
Veja, neste caso, é um artista, a pessoa leva foto e ele imita o rosto da pessoa. Então, tem um impacto social diferente, mas realmente não tem a certificação de qualidade. Se puder traduzir para ele.
Ok.
Eu acho que ele não tem.
Maybe not. Professor James, just an additional information that Professor Anna just gave to me. We totally agree with you in terms of protection. That should be okay. But she's saying that there is another face of it, that he's imitating the real face of the person, and there is a social aspect of it in terms of even accepting more, this kind of a mask. It's just for your information, in case I could not translate it properly initially.
Yeah, I'd have to see something like that to fully understand the concept of that, where you can make a mask looking like another person or so on. I'm not exactly sure what the intent of that is. That might be a cultural thing. We see people making fun of President Trump by wearing a mask like that, or maybe a pig or something of that nature. Again, it becomes more an art expression than it is a protectionist expression.
Eu vou mandar um vídeo para ele, onde imita o rosto de verdade da própria pessoa.
Okay, and she's saying that she's sending to you a video that you could see and enjoy what you are just trying to explain, and you see the masks. Okay.
And maybe they're just missing Carnival.
Maybe. Agree. But yeah, because we are not going to have this very soon, so maybe
it's the same face. It's the same face. My face, either mascara. It's the same. Not Carnival. Carnival is good, but not in Brazil. No Carnival. But the artists make compare real photos, the same face, bush, nose, looks like, but no, don't have the quality.
Yes, yeah. I'll have to see this. You're ahead of us. You're way ahead of us in this area.
Okay, and Professor, besides the Apollo's book that you just showed to us, do you have any publication of this specific topic that you can spread with the audience in Brazil?
Yes. What I'll do is I will not only send you the PDF of what I presented to you, but also I will send a list of references, not only presented in the data that I presented you, but also supporting information based on stuff that I have done as well.
Thank you so much. Então, pessoal, o professor ele vai passar uma lista para a gente de alguns artigos, né, que cobrem esse tema para depois nós podermos ter contato com o material de pesquisa dele. And finally, Professor, it seems that we have a lot to improve in terms of the usage of masks. Is that right?
Yes, absolutely. There's, the science is still being developed. I pointed out some of the difficulties that you can see there, and probably the biggest takeaway message is that it's very easy to demonstrate in a laboratory how well a mask can protect because they put it on a mannequin. I don't know if in Brazil they showed you airplanes where they had mannequins and they say the particles don't spread, in a mannequin, but people are different, right? They're talking and they're moving. There's going to be a lot more spread, but as I always tell my students, this is the important thing. Remember these 3 words: follow the money. When you follow the money, you can understand why things are the way they are. So when people are resisting and they know they're taking a chance going to a restaurant or going to a gym or going to a bar, basically those bars are open because they're trying to make some money at the risk of someone getting sick and possibly dying from that exposure. Not maybe directly, but maybe when they go home to their older parents and so on. So the key thing is that we have differences between what we see in the science of laboratories versus the real world. But in the end, what I've seen more and more, especially when businesses are pushing really hard to stay open, airlines are pushing really hard to fly as many people when they're told not to fly, because they could have said, we're not going to fly, because it's a bad thing. They're all flying. Why? Follow the money. So keep that in mind, and I think you'll always get some answers for that. Sometimes not answers you like, but you will get answers.
Yes, I totally agree. Very wise, very wise. Só uma pergunta rápida, pessoal da administração do CEMEAD, a gente tem tempo para mais uma pergunta ou finalizamos aqui?
We have time?
Yes.
No,
Okay.
no, in the system. Big
Yeah,
system.
she's not speaking, but quickly, Professor, is there good news in terms of the end of this pandemic?
Yes, I think there's very good news. There's 3 different companies. Pfizer, I actually have a friend who is on the lead team for developing this vaccine. Pfizer's one, Moderna is another, and they use what's called messenger RNA for developing the vaccine, which is a whole new way. It's like basically a genetically engineered coupling for stopping the spread of the virus particles in the system. And it looked very, very promising at 95% effectiveness. And then Oxford and AstraZeneca have come out with a more traditional approach. They've taken longer to do this. And remember, they were working on Zika and SARS-1, so they had a longer run time of this, more traditional way, and so that's coming out. So you have 3 vaccines. Now, Russia's reported they have one, China has reported they have one, and so on. And I don't want to disparage either country, but the field trials and the rigorous elements that are involved in large populations to be tested so there's no adverse outcomes, that due diligence has been done. And so I could say by the time we reach next year at this time, the world will be vaccinated. The vaccine supply will be there, because it's not just making the vaccine, it's a supply chain, right? Getting the vaccine from here and the people vaccinated. I mean, that's a big, big step between having it and getting it administered. That's real big. But I believe that because the world is on alert, we will be in a much better place next year at this time. So that's the great news. Drugs such as remdesivir and others have shown that people who are infected, they can mitigate those symptoms and so on. And many fewer are now dying. And we're learning a lot more that you don't have to put someone always on a respirator when they get into bad shape with the lungs full. They can put them on their stomach. and give them oxygen. So treatment regimens have greatly improved significantly. And you see that both in your country, as well as the United States and other countries, where we've gotten a lot smarter about people who are infected and they come in. So we're reducing the mortality. Case rates, are going up, but I think the cavalry is coming. The rescue will be here. Unfortunately, we've just got to be very, very careful to be kind to one another, lower the temperature, and try to make it through to next year, because good days are coming. What would thrill me more than anything would be to be there in person to give all you a big hug, face to face, and not through this screen.
Yeah, absolutely.
Yeah.
Hopefully, Professor, hopefully. And these are great news indeed.
Fantastic. Fantastic.
Okay.
Thank you so much.
No,
So
my
much.
pleasure. Thank you for inviting me.
Wonderful.
Again, I will send the information, the references, and the PowerPoint presentation to Chris. And I want to thank all of you for the opportunity to present. I hope you found it informative and useful. And I'm available for any follow-on questions by email if you like.
Okay, Professor. Good. I wish to you a good Thanksgiving tomorrow, and I appreciate your time. Thank you, Professor Ana Cristina.
Thank you, Ligia. Very, very thanks, James. Wonderful. So finishing.